Good morning. This is Dr. Paul. Thank you very much for tuning to our channel today. Today I want to talk a few minutes about treatment of hyponatremia, and it's a difficult topic, but if you pay attention it will be easy. First let me classify it. As I said, there is isotonic hyponatremia, which is caused by hyperproteinemia and hyperlipidemia. And we have hypertonic hyponatremia when there is hyperglycemia and when there is mannitol. And finally there is hypotonic hyponatremia. So isotonic, hypertonic, hypotonic. Hypotonic is again three types: euvolemic, hypovolemic, and hypervolemic. So this classification, I am mentioning this classification because if you know this classification, you will search for etiology, and etiology determines the treatment of hyponatremia. So whether hyponatremia is symptomatic or not is very important. Now let us start. What are the most important things when you treat hyponatremia? Hyponatremia can be chronic or acute. If it is a chronic hyponatremia, you don't have to be rush. You don't have to rush to treat it because the body has that ability to adapt to that low sodium level. But if it is acute, because if it developed in the last few hours and the patient is asymptomatic, then you need to treat that hyponatremia immediately. And the treatment differs. And here, mild hyponatremia, like when the sodium is between 130 to 135, it is usually asymptomatic. So when you see mild hyponatremia, don't just rush to treat it. See what are the symptoms and signs the patient is having. So if the patient is having symptoms, then you can treat it. But mild asymptomatic hyponatremia, you don't have to rush in treating it. Now what are the clinical features? It can cause hyponatremia, can cause headache and nausea, vomiting, and patient getting paralysis, and sometimes even respiratory arrest. Sometimes patients can get seizures and go into coma because, you see, hyponatremia can cause permanent brain damage, and it can cause brainstem herniation and even death. So hyponatremia is not like hypomagnesemia or hypocalcemia. It's a dangerous thing. It can kill people if it is severe. And the other thing is, when we have this hyponatremia, sometimes patients develop hyponatremic encephalopathy. Hyponatremic encephalopathy can happen, and it can, if untreated, it can lead to serious brain damage and death. So remember the clinical features. Most of these clinical features are reflective of cerebral edema. Then look for the other clinical features. What led to hyponatremia? Is the patient being given any hypotonic fluids? Is the patient developed vomitings, diarrhea? Is there any ostomy output from the patient? Is he peeing too much? Any polyuria? Not peeing anymore? Oliguria? And are there any insensible losses of the fluid? Because, as I said, volume status of the patient is very important when you treat hyponatremia. And if you don't see for the volume, you lose everything. So physical examination is very important. You see whether patient is euvolemic, hypovolemic, or hypervolemic. Remember one thing, folks. You are not treating a number. Hyponatremia, you are not treating a number. You are treating people. You are treating a person. That's a very important thing to remember when you treat hyponatremia. Of course, that's important for everything in medicine. When you see an X-ray, chest X-ray, you are not treating chest X-ray, you are treating a person. When you see a CT scan, you are not treating a CT scan, you are treating a person. In the same way, hyponatremia, you are not treating a number, you are treating a person. And that person's history, physical examination, and labs, everything plays a role. Before you do anything, you need to gather this information, and then you jump to treat the problem. So first establish the volume status, because volume status determines what you do with the patient. So you see, let me recap the clinical findings, the symptoms. Patients may not have symptoms if sodium level is more than 125 milliequivalents per liter, but if it goes down, patients develop cerebral edema. When cerebral edema comes, patient develops like headache, nausea, vomiting, mental status changes, disorientation, inappropriate speech. And if it gets worse, it can develop even seizures and coma and brainstem herniation, hyponatremic encephalopathy, and even death. So, look for the symptoms and signs. Does the patient have these things? Then look for the volume status. Then measure the sodium. Like you see, I told you before that when we see in hyperlipidemia, hyperproteinemia, that is isotonic hyponatremia, we see pseudohyponatremia. So you don't have to treat it. But in hypertonic hyponatremia, like hyperglycemia, mannitol administration, then you need to use correctional factor. For every 100 milligrams increase of glucose, you need to add sodium by like 1.5 to 2. So you use correctional factor in hypertonic hyponatremia untreated. In isotonic hyponatremia, caused by hyperlipidemia and hyperproteinemia, you don't even treat it because it is pseudo-hyponatremia. So you see the point, you are not treating the number, you are treating the patient. And the patient will come with his increased volume sometimes. And the volume status also, it determines how you do with the patient. So many times history plays a role, physical examination plays a role, and also the laboratory tests. For example, if the patient has hypertonic hyponatremia due to hyperglycemia, if you don't have blood sugar level with you, you cannot do anything. Now I want to say a few things about SIADH also. SIADH has 5 things. Number 1, hyponatremia. Number 2, decreased osmolality. Number 3, absence of heart, kidney, and liver disease. Patient should not have heart, kidney, liver disease to say he has SIADH. Number 4, patient should have normal thyroid and adrenal function. You say they should not have thyroid and adrenal disorders. Number 5, urine sodium usually more than 20 milliequivalents per liter. So those are the 5 characteristics of SIADH, and it's a clinical diagnosis. So the 5 things are hyponatremia, decreased osmolality less than 280 milliosmoles per kilogram, then absence of heart, kidney, and liver disease, then normal thyroid and adrenal function, and finally increased urine osmolality. So look for those 5 things. If the 5 things are there, the patient is having hyponatremia due to SIADH. And those 5 things will help you to establish that. Because if you suspect SIADH, you are not actually measuring ADH. We don't do that in clinical practice. And even though it is SIADH, we take those 5 things, and if the 5 things are there, you say the patient is having SIADH, and you treat accordingly. So you see the importance of history here, the importance of labs. And also any azotemia is happening. Sometimes there is volume contraction. And if you see hyponatremia, that's not SIADH. You remember what I said, SIADH is seen only in euvolemic patients. The hyponatremia in SIADH is euvolemic hyponatremia. That's a very important thing to remember, folks. Now let me tell you some most important things. The most serious complication of hyponatremia treatment is iatrogenic cerebral pontile myelinolysis. That's the most serious complication. Remember that. Iatrogenic cerebral osmotic demyelination. There is another name like pontine myelinosis. Same thing. So this thing you should always keep that in your mind when you're treating a patient with hyponatremia. And so all patients with clinically significant hyponatremia, first put them in the hospital. It's not an outpatient thing. And once the patient develops symptoms and signs suggestive of hyponatremia, put them in the hospital. There are any seizures or mental status changes, take them to ICU. That's where they should be. And that's where you should treat them. Because the progression can happen very, very quickly. So hospital and ICU, that's where you treat them once they become symptoms. Then as I said, volume status, that is the one thing you need to see. Then many times restrict free water and hypotonic fluid intake. What happens if you give free water to this patient, their total body volume will increases and sodium level falls down. If you give them hypotonic fluids, again same thing. Their sodium level falls down as their water level increases. So restrict free water, restrict hypotonic fluids, and also be careful how you treat it. That's very, very important. If you treat hyponatremia rapidly, the patient can go into cerebral osmotic myelinosis. And that's a very, very serious condition. So it is like, so first establish the volume status and treat it. If the patient is hypovolemic, give fluids. Because you see, hypovolemia can stimulate ADH secretion. So you need to treat hypovolemia also and take away that stimulation of ADH secretion. And if there is hypervolemia, give a diuretic or dialysis. So you see, euvolemic, restrict fluid, hypervolemic, use loop diuretics or dialysis, hypovolemic, give fluids. Simple. And if you know that simple classification, it's just common sense. If the euvolemia, just restrict fluid. And I said hyperlipidemia and hyperproteinemia, these two things can cause isotonic hyponatremia, which is a pseudo-hyponatremia, and you don't even have to treat it.
Oh no, it was heavens, not back up.
Then we have translocation of hyponatremia when there is high glucose level. or when the patient is mannitol, getting a mannitol concentration. In that case, you need to correct the glucose level. You need to stop mannitol administration. That is the treatment. You see how many things you are doing. And when there is a symptomatic and severe hyponatremia, then comes the administration of fluids. We need to administer 3% saline to these patients. What is it? Here, okay. Thank you. The other thing is you need to see what medications. Sometimes medications cause hyponatremia and you should stop those medications also. So giving fluids, restricting fluids, everything is there. The point is establishing the underlying cause. First establish the underlying cause. That's what you are treating, not the number. And also, if the patient is symptomatic, you need to treat aggressively but slowly, not too much. The correction should be like 10 to 12 milliequivalents per liter in a day. That's over a day. That means you need to calculate the rate, go 10 per day. That means if it is mild, then go very, 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 very slow. If it is very symptomatic, correct 1 milliequivalents per liter per hour. And if the patient is getting better, symptoms have gone, then slow. Bring it to bring the correction to 0.5 milliequivalents per liter per hour. So when the patient is symptomatic, you need to check sodium levels every 1 to 2 hours. And the symptoms are improving, then slow down. You were going 1 milliequivalents per liter per hour before, now reduce it to 0.5 milliequivalents per liter per hour. Why? Because overcorrection is dangerous. That can ruin everything. As I said, central pontine myelinolysis, same thing it's the same thing, cerebral osmotic demyelination. Both are same things for the same names, different names for the same thing. Basically, demyelination is happening with sodium correction. And if you take an MRI, you will see white matter lesions in the pontine and extrapontine areas. And also, during that time, patients develop hypoxia, and that hypoxia leads to demyelination. And once the patient develops this condition, it is irreversible and catastrophic. I saw only one patient in my residency, and that's a heart-rending story. I don't want to even go into the details of it because the sodium was corrected so fast that patient ended up in coma and then came back and stayed in permanent paralysis. There is no treatment for central pontine myelinolysis. You only can prevent it. If the patient develops these things, forget about it. Wait for the lawyer, because there is nothing to come out of that. So hypertonic saline, you can give it, but use carefully. And also, as I said, volume status is again important. What happens if you give hypertonic saline to a patient with hypervolemia? He develops, there will be extracellular fluid coming up, and patients develop pulmonary edema and die. So if you give hypertonic saline to hypervolemic patients, you are again causing damage like pulmonary edema or ascites. So you need to be careful, folks. That's the main point. What is the volume status? You need to establish that. There is no way you can neglect that important thing. And even if you're treating a severe hyponatremia in a patient who is in hypervolemic state, you need to be careful when you're giving that. And finally, I want to say a few words about vasopressor antagonists. That's the medical therapy. That's where we use the medications. And we use these medications for isotonic or euvolemic and hypervolemic. And these vasopressor antagonists, again like demyelination, that's the most important thing. Demyelination, you can use this medication, but in cirrhotic patients it can cause nephrotoxicity. Vasopressin antagonists, and they are very useful in the treatment of euvolemic and hypervolemic hyponatremia. You can use only in those things, folks. Euvolemic, hypervolemic. Euvolemic, example Siadh. Hypervolemic hyponatremia, example heart failure. Okay, there are like agents like Cerebral, and that's a oral selective vasopressor to receptor antagonist. So these, you don't have to worry about the names, Lixivaptan, Tolvaptan, Cetabaptan, there are all these names. And they are basically oral selective vasopressin 2 receptor antagonists. Basically they are acting against ADH. And these medications basically they act against, in euvolemia, for example, you can use Conazepam in Siadh, and many people are using that in the hospital. So vasopressor antagonists can be used if, for example, if a patient came with Siadh and you need me? Yeah.
I need your initials here and your signature right there. It's for vaccines for children.
Oh, okay. Thank you. Thank you. So let me recap and I will finish. Classify. Isotonic hyponatremia caused by hyperlipidemia, hyperproteinemia. Then hypertonic hyponatremia caused by hyperglycemia and mannitol. Then comes hypotonic hyperglycemia. And hypotonic hyponatremia is again 3 types. Hypovolemic, euvolemic, and hypervolemic. Classify that first. And then treatment. And the treatment is most effective when the underlying cause is corrected. Look for what is causing this problem. And treatment is most effective when you treat the underlying cause. If you forget that, if you just treat the number, it doesn't help you anyway. So folks, remember those points. And I'm sorry if I confuse you, that's not my intention. And you can always share your points and visit me at www.drpaul.org. That is www.drpaul.org. Thank you very much. Have a nice day.